We are very pleased to welcome 5 clinicians today who will discuss distinct approaches to virtual care in a clinical geriatric context. Dr. Mireille Norris will discuss the Telemedicine Impact Plus program at Sunnybrook Health Sciences Center. Dr. Norris is an internist and geriatrician at Sunnybrook Health Sciences Center and is a physician lead for quality improvement and postgrad education for the Division of Geriatrics at Sunnybrook. Her role also includes assistant professor of medicine at the University of Toronto, and she is also the director for Sunnybrook Hospitalist Training Program, which she created and implemented. Rita Mileykovsky will discuss OTN use and specialized geriatric services at Baycrest. Rita has spent 14 years working as a registered nurse directly with older adults. She is Baycrest's first virtual care nurse, co-creating the virtual care environment and leading multiple innovative technologies and processes of care. She works with older adults remotely on a daily basis. Dr. Marisa Zorzitto will discuss the Geriatric Medicine Telehealth Clinic at St. Michael's Hospital. Dr. Zorzitto is a geriatrician at St. Michael's Hospital and head of the Division of Geriatrics there for 17 years. She is also the medical director for the Regional Geriatric Program, Specialized Geriatric Services at St. Michael's Hospital, and an assistant professor at the University of Toronto. Dr. Zorzitto has been providing telemedicine to underserviced communities north of the GTA for 14 years. And finally, Janny Lee and Nicoda Foster will discuss Sinai Health System's telemedicine program. Janny is a clinical nurse specialist in geriatrics at St. Michael's Hospital and continues to support the telemedicine program at Sinai Health Systems for homebound older adults in Toronto. Nicoda Foster is the program manager in the Healthy Aging and Geriatrics program at Sinai Health Systems. She is currently pursuing a PhD at McMaster University in Health Studies. Before we get started, I'd like to let you know how to engage with our presenters today. Please type any questions or comments you have in the chat box at any time, and we'll start a question period by 12:45. I will answer the most commonly asked question: can we have a copy of the slides and recording for the webinar? Yes, you can. We'll send them to attendees and post them on our website and YouTube channel. And with that, I'd like to invite Dr. Norris to take the stage to discuss the Telemedicine Impact Plus program at Sunnybrook Health Sciences Center.
Good morning. I'm happy to join you to discuss Telemedicine Impact Plus program. I'm present with Kim Garvey, who is the nurse facilitator on the program. Next slide. This is a unique program. It stands for Interprofessional Model of Care for Aging and Complex Treatment. It is a novel approach to caring for patients with multimorbidity. It is an OHIP billable service that supports coordinated care with allied health, home and community care coordinator, and relevant services. It is part of a CIHR-funded RCT. You can see the link to a paper published on the program below. Next slide. In this slide, you can see how telemedicine technology can virtually link the primary care provider on one side with the patient and tip nurse. On the other side, you have the interprofessional team, which can include allied health as well as medical specialists. At Sunnybrook, geriatric medicine and geriatric psychiatry are frequently present. Sometimes the team is tailored for the patient's need, and a nurse educated from diabetes can be present, or a nephrologist. Next slide. The referral process requires completing a form, which can be accessed to the link below. Phone numbers, email, and fax are also available. As we mentioned, the tip consult involves a team. Please, next slide. This is the form. Next slide. Patients who benefit from TIP typically have high caregiver burden, and they have cognitive impairment, mental health conditions, substance use disorder. They have challenges that involve the determinants of health, such as housing. They have frequent emergency room visit and hospitalization. They are often unattached or poorly attached to primary care. They often have physical impairment and chronic medical comorbidity and polypharmacy. Such patient is at high risk of institutionalization. Sometimes they are uninsured. Next slide. This is a slide that identifies the referral process. First, the patient may be referred by primary care or the emergency room. The nurse contacts the patient and arranges a home visit. She reviews the chart and contacts the family doctor. She convenes for an appropriate date for the team to meet, and the OTN session is booked. The OTN event is conducted, and during that time, the nurse documents recommendation from the team. She completes a coordinated care plan, which is validated by the rest of the team through email communication. The coordinated care plan is entered and can be accessed on Connecting Ontario. And following the intervention, she monitors progress and recommendation. Next slide. In this picture, you can see the team. You can recognize Dr. Sinha, who's surrounded by other team members, and through the camera, there's an example of a patient with a primary care provider. Next slide. This is a real-time dynamic and iterative process between patient, caregiver, primary care provider, and interprofessional team. The patient is introduced to the camera and welcome. The focus is identifying the patient's goal. This is a process where everyone is joining in, different members of the team, as seen relevant, and in this process, team members learn from each other, and a healthcare plan is developed. Next slide. This is an example of a case. The patient's goal was to stay home and not return to the emergency room. He's an 80-year-old socially isolated senior who declined home care. He came to the emergency room after a fall. He was taking the TTC on his way home, overshot his stop, tried to walk home. In the emergency room, he denied falling. His past medical history includes chronic kidney disease, stage 4, type 2 diabetes, dyslipidemia, hypertension, and anemia. His medication includes doxazosin, furosemide, atenolol, Crestor, and insulin. On physical examination, his blood pressure is high, HbA1c is low, and troponin are slightly elevated. The gen nurse and the OT who see him in the emergency room make the referral for a home safety visit by the community care OT and initiate the TIP referral. He is advised to use a walker, but refuses a personal support worker. He's also referred to the fall prevention program and offered to obtain a lifeline. The internist who sees him in the emergency room considers that there is no active illness and refers management of the blood pressure to the family doctor. The nephrologist recommends a BD scan given elevation of troponin. Next slide. On the initial assessment generated by the nurse, on the physical health section is the finding in the emergency room. She identifies that the patient lives alone. We don't know his financial situation. He drives to get his grocery. He misses meals frequently. The neighbor who helps him is not the substitute decision maker. He's not known to have mental health problem, but we recognize that he may be drinking a bit much and is hearing impaired, but denies that. His family doctor is not aware that he's not taking his medication and doesn't know his home situation. Next slide. So nothing happens in isolation from other factors. Those factors may be invisible in the acute care and unknown to the family physician. We want to know what are the patient's goals. Next slide. So during the TIP meeting, I noticed that the patient's voice is hoarse. We also recognize that he is hearing impaired. We can see that he is cachectic. We suspect that he's likely cognitively impaired, as there's an association with chronic kidney disease and hearing impairment, so that during the session, we ask for a MoCA score and a pill count. And we recognize then that his MoCA score is 16 out of 30, and that he takes half of his pill. He's still taking insulin while missing meals. He declined a home visit and is not using his walker. Next slide. So this is the care plan that is devised after the TIP consult. With regard to the TIP management, we recommend stopping insulin. For medication management, we recommend blister pack home care nurse who will monitor medication compliance, blood pressure, and blood sugar, and we recommend obtaining a blood pressure machine. To investigate the weight loss, we recommend various consultants as well as a dietitian to visit the home. Now that the patient is recognized as having cognitive impairment, a social worker is recommended for facilitating obtaining a power of attorney. We suggest that his driving license be revoked. He will need assistance for shopping, and a referral is made to the IPC team at Baycrest, and an audiology referral is recommended. Now that we see that he's cognitively impaired, we recommend the day hospital rather than the fall prevention program. And to improve access to care, the nurse facilitator will monitor the patient over the next 6 months. Next slide. So the TIP benefits patients as well as the healthcare system. There's a high degree of patient satisfaction. The team also feels satisfied that technology facilitates collaboration. And early results from data collected across 5 Toronto Central LHIN subdivision showed that there was a reduction in emergency room visit post-TIP in the 6 months following the intervention. Next slide. Opportunities for improvement. We would like to see increased consistency in primary care provider attendance. We think that we would benefit from having the primary care provider perspective, and them being present would help facilitate implementation of recommendation. It is recognized that specialist consultation may still be needed and can be difficult to access. And we find that patients still need advocate, ally, or navigator to help implement recommendations. Thank you for your attention.
Thank you very much, Dr. Norris. We would now like to invite Rita to discuss OTN and specialized geriatric services at Baycrest.
Thank you very much, and thank you for giving the opportunity to talk about virtual services at Baycrest. We use virtual care in a few ambulatory settings, including the day hospital outreach teams that were mentioned previously, for example, IPCT and geriatric clinics. In the interest of time, I will introduce one of the services we are offering our clients at the Geriatric Day Hospital, which is a virtual home assessment, or in short, we call it VHA. Next slide, please. A little bit about the program before we dive into the VHA. So the Wellness Path program at the Day Treatment Center is a 12-week outpatient program that is tailored to a patient's individual needs. So clients attend a 3-hour sessions twice a week to receive services from an interdisciplinary team, including a geriatrician, OT, PT, RN, social worker, as well as an SLP. And a lot of the referrals to the center are due to the falls, and most of them happening in the home. And all services are provided face-to-face during the visit. And these visits are basically limited in that Baycrest clinicians have little knowledge of the actual configuration of the home environment, which is very crucial to make any recommendations, for example, by the occupational therapist. So what we've done, we basically removed this limitation by using telemedicine as a channel for the clinician to be virtually present in the client's home. We virtualized the existing face-to-face service. The goal of the VHA, as the traditional one, is to examine the living environment, denote any areas that may potentially create problems or dangers for the client, and then distinguish any modifications that make the living environment safer and hopefully more functional. Another goal is to increase access to the right care in the right setting at the right time by having this virtual window into client's home, and to offer a one-stop model to seniors in the community without engaging a third-party community resource such as LHIN. So prior to a virtual home assessment, a general practice was, when needed, a referral for a home safety assessment was sent to LHIN. But by the time the assessment was completed, the client was near or could have graduated from the program, so would not get the reports on time. Next slide, please. So how we identify the clients, potential clients for virtual home assessment are identified by clinicians during clinical rounds around the third week of clients attending the program. To address safety, clinicians also assess clients for their physical and cognitive ability to participate in virtual visits. We have developed a screening form to guide the clinicians. For example, are there any medical or cognitive conditions that may impact the ability to handle or learn new technology? As well as we screen for comfort level and ability to use the technology. So based on that screening, we might also exclude clients who are deemed inappropriate for video conferencing. Another reason for exclusion could be if the client does not consent to the virtual appointment. But it is also important to mention that we think about how we can turn a no into a yes to participate in the virtual visit. And this is when we developed an accommodation plan. For example, having an extra person, a family member, or anyone in the circle of care during that visit to help and handle the technology. Or we might want to modify the virtual visit itself, for example, by not asking the client to perform some functional tasks during the virtual visit, such as transfers in and out of bed or to a bathtub, because these can be done while the client attends the program at Baycrest. Next slide, please. So how is it done? The referral for the virtual home assessment is usually through an order in client's chart by the geriatrician, but it can also be requested verbally by any clinician. The clients give consent to the clinician on the team, and then they're referred to the virtual care nurse for training and tech deployment. For clients' convenience, we are providing them with an iPad that is equipped with data and all the required apps, including the, for example, Infinity Connect, as well as an email account to receive the OTN invite. But they can also choose to use their own devices if they want to. In terms of the training, so the virtual care nurse trains the client or the family member. They practice joining the video conference via the invite until the client feels confident in operating the device. We also simulate the actual virtual visit. We walk around with the device, and then we give you the device to take home along with written instructions. Important to mention that the training happens as close as possible to the actual virtual appointment, preferably even the same day, especially for those with memory issues. The virtual encounter at the time of the scheduled appointment, the client or the family member join the clinician virtually, which is often the occupational therapist who has already developed an assessment plan. And based on that, the client is then guided through the different areas of the home. At the end of the virtual appointment, the clinician discusses the identified issues and recommendations. And often the OT would say, you know, these are the things that we can work on with you when you come back to the day treatment center. In terms of the documentation, so the report from the virtual encounter is documented in the client's chart in our ANR, as well as a brief summary provided in the discharge letter to the referring source and family physician. So you can see from this process, in terms of the resources that are required, we would need a device to connect with the client remotely. We needed to develop a workflow and forms. We would also need someone to train the client as well as to do the actual virtual home assessment. And an ongoing access to troubleshooting is also required. And for all of the above, we would obviously need to coordinate with our and clients and family schedules. So some coordination is needed as well. Next slide, please. When it comes to advantages, assessing the home virtually right away gives a clinician some lead to start working with a client and focus on risk factors that were identified during the virtual home assessment. As well as the virtual visits are very timely and direct, and the staff has more control of arranging the appointments. They can always refer the clients to the community partners, but having access to the virtual visit eliminates the need of involving, like they say, another cook in the kitchen. So it is really helpful having the day treatment center clinicians to be the ones to identify, validate, and then follow up with the issues that were assessed during the virtual visit. As for the clients, we learned that virtual home assessment enhances their ability to receive the assessment in a timely manner, as mentioned above. But we also learned that we're enhancing older adults' experience with technology and making them feel more valued. Some clients have even stated they feel very proud of themselves, to be able to connect with OT virtually. And they talk about the virtual encounter when they come back to the day treatment center with other clients. They talk to their neighbors and their family members. So they feel valued, and the satisfaction rate is pretty high. For the challenges and some of the solutions, one of the next slide. Oh, no, sorry, that was the one. One of the challenges is getting consent from the client. So the idea of having a stranger looking into their home can be uncomfortable for many clients. And it is their private space. But in the day treatment center, our team takes extra effort to build rapport with our clients to reach a certain level of comfort. And this is helpful to allow the eligible clients to be open to participate in this virtual initiative and welcome the team into their home. As for the coaching for the clinicians, we introduced an innovative change in practice, a virtual home assessment, which was not originally part of the program. And that requires collaboration from clinicians, including their time and effort. So for successful adoption of virtual care, we provide training to the clinician addressing any gaps when needed through an open dialogue. And as well as we co-design with clinicians as well and provide ongoing support to optimize the experience. Technical challenges, as much as we love technology, not always we're able to connect with the client smoothly. We might have some delays in the picture or sound, especially in certain areas in the home, such as basement. So this requires some level of support for troubleshooting. So when the visit is initiated, the virtual nurse usually is available if needed, just to make sure that the client and the clinicians are able to connect with each other. I guess I don't have time for success story, but in general, a success story for us is when we're able to assess the home virtually, generate recommendations based on the client's needs in their environmental context, and then continue working with the client on the identified issues at the day treatment center.
Wonderful. Thank you very much, Rita. We'd now like to invite Dr. Zorzitto to discuss the Geriatric Medicine Telehealth Clinic at St. Michael's Hospital.
Good afternoon. Actually, the telemedicine clinic from St. Michael's to regions north of the city, underserviced areas, originated from a face-to-face outreach clinic, which started in about 2002. But in 2006, instead of traveling to Aurelia, OTN incentivized the initiation of these virtual geriatric clinics. So the first site was Aurelia, but then very quickly other sites came on board, and they continue to be ongoing. And the purpose of this program would be to provide comprehensive geriatric assessments to patients that have been identified by the providers at the other end in these remoter communities. It's meant to improve access to specialized geriatric care, provide education to family members who are in great need of such information in knowing how to take care of their elders, and to build capacity in the rural providers. In other words, it's another form of providing continuing medical education through practice. Next. So some of our processes and the resources may seem to be intensive, but relatively straightforward. At the other end, there is either a nurse practitioner, occupational therapist, or family physicians that actually identify the patients They obtain consent for the patient to be interviewed via telemedicine as opposed to face-to-face, and they are entered into a schedule. The involvement at the other end when the assessment takes place is done with the assistance of either a nurse practitioner, a nurse, an occupational therapist, and a lot of the times even by the telemedicine coordinator, who is often or almost always a nurse. So during the consultation, this individual would be the hands-on person while the interview is taking place via OTN. The consult involves much of what you would expect in a comprehensive geriatric assessment, which is a review of the history, which is often provided, the medication lists, screens for depressions, cognitive screening, sometimes even more comprehensive cognitive screening, the physical examination, and you would be amazed how much you can observe and learn just by paying it close attention, which sometimes is challenging. There is a large focus on the neurological assessment, including balance and gait. And then at the end of the patient interview, the family gets a half an hour or so of time to ask questions, to get additional information about initial impressions or diagnoses about what's going on. Often it has to do with cognitive impairments or movement disorders. That's variable. Now the resources are required. At their end, the space has to be safe and secure, but even at our end, at the St. Michael's end, the space has to be safe and secure and private. You need cognitive testing tools at hand at the other end, fax machines, old technology, fax machines, sorry, telephone, and a secure email system so you can communicate other than through the virtual teleconference itself. You need some equipment for the physical examination, patellar hammers, things of that nature, but nothing too sophisticated. And then you need some augmentative devices like maybe headphones so that people that have hearing problems, or at one time I needed an individual who could do sign language because the patient at the other end was quite deaf and hearing impaired, and no other means of communication was possible. Next slide, please. So what are the factors for success? You have to establish a relationship with the referring physicians. Thankfully, I was able to do this when I was actually doing the on-site visits. And so I already knew some of the physicians at the original site in Aurelia. Then you need local institutional support and commitment to elder care. If your service isn't going to be useful for the providers, the healthcare providers at the other end, the referrals just won't be coming in. You need trained and knowledgeable clinicians at the remote site. And most of the nurses at the remote sites, and they're almost always nurses or nurse practitioners, they have actually been cross-trained to do some of the hands-on physical assessment while I do the observation. You may need adjunctive equipment to accommodate the patient's needs, maybe a special bench or a walker around because they couldn't bring theirs in. But it's nothing too sophisticated. You also need the space. Now, the telemedicine processes and protocols, you certainly need to let the sites that are making the referrals know what the inclusion and exclusion criteria are, and they have this information. They provide pre-clinic assessments, a summary of the patient's history, and the questions that needed to be answered, the medication lists, if that is possible. And usually there is an individual that accompanies the patient, him or herself. The nurses at the other end know what the clinical assessment sequence is. So we go from asking the questions, the functional assessments, the cognitive screening, and so on and so forth. And they know the steps that are taken so that we're really working very synchronously with one another. The documentation, dictation is done almost on the same day. They should have reports within the 2-week time frame. And the dictation takes place through the St. Michael's system, because these patients are patients of their site, but also patients of St. Michael's Hospital. So privacy is maintained, and then follow-up is arranged by the patient site. Next, please. So the challenges, and there are challenges, technology is a challenge. Sometimes the network isn't stable. That I've found over the years, and I've done this for many years now, is that there's a high turnover rate of the staff that operate the OTN system at the other end. There are financial pressures, so that initially it was the hospitals at these sites, Midland, Aurelia, Collingwood, that were providing the telemedicine support. But now there's a great interest in the family health teams taking on this role. The local community and hospital resources also may be a challenge, because as a provider of the service, I have no control over whether the recommendations are actually taken up. And I also don't know what the resources are, and I'm learning just as they're learning. I'm learning what the resources are in Collingwood, but maybe I don't know if a new site comes on board what resources are there. And then they have a lot more difficulty in some of these communities to get access to some tests that we would consider in Toronto to be fairly common, like sleep studies or MRIs. The patient suitability sometimes is a challenge. The level of education of the patient, language and communication barriers. Very often they select individuals at the other end that seem to be appropriate for this. So I haven't run into too much trouble over the years. You need a family member to support this and bring the patient to the clinic. And older adults may not be totally accepting of the technology. As for physician resistance, very little physician resistance since this is an insured service and there's good reimbursement for it, but it's not a time saver, and it is very intense mentally because you have to be observing the monitor and what is going on for literally hours if you're doing three patients in one go. Next, please. So there's no question that it increases access to geriatric assessment and care. There's no question, and patients tell me this all the time, that they're very thankful they don't have to travel to Toronto. They're very thankful that they don't have to spend time at a hotel or travel long distances and spend money, and that they don't have to wait a long time to get the service that they need. From my point of view, I don't have any missed appointments, unlike my clinic, which has quite a few missed appointments. My wait times for this are decreased, and I don't need any bricks and mortar so that other people are using the space at my sites and I'm using OTN resources. And there is also no question, and I get this feedback from the nurses at the other end, that that they are learning. They're learning to do better assessments and to provide better services in their community for these patients. So my good news story, next slide, is that we've been doing this now for 14 years. We've changed technologies from room-based systems to mobile telemedicine to now the personal computer in my office. We've increased the number of sites, and we've gone from hospital-based mostly to community-based and family health teams. And we have by now, which is 2020, over 1,200 visits using this video conferencing.
Wonderful. Thank you so much, Dr. Zorzitto. And finally, we'd like to invite Janny and Nicoda to discuss the telemedicine program at Sinai Health System.
Yes, hello, good morning. This is Nicoda Foster speaking, and I'm here with my colleague, Janny Lee. So thank you very much for inviting us to speak about the telemedicine program here at Sinai Health System. So I'm just gonna move to the next slide. So the Sinai Health System Geriatrics Telemedicine Program started in 2012 as a quality improvement initiative that was funded by the TC-LIN, or what was the TC-LIN at the time, to essentially support a group of primary care physicians who provided home visits to older adults who were frail, as well as homebound, to help them connect to hospital-bound specialists. So the program itself essentially is built around a telemedicine nurse who has mobile access to facilitate consultations between the specialists, as well as the primary care providers and their homebound patients. The program, in terms of the boundaries that we operate within, we still operate within what has traditionally been known as the TC-LIN boundaries, but there are some cases where we'll go outside those boundaries, and we have a few patients also living in long-term care facilities as well. Just moving to the next slide. So the geriatrics, the Sinai Geriatrics Telemedicine Program is really built around a nursing role that really works on facilitating the connections between the patients, the primary care providers, as well as the specialists. The telemedicine nurse is typically a clinical nurse specialist who has advanced training in providing consultations as well as doing comprehensive geriatric assessments. The nurse has both clinical as well as administrative functions and does a whole host of things, starting from triage to coordinating across different providers, not just the primary care provider or the specialist, but other providers as well within the patient's circle of care. And there's also a significant amount of case management and follow-up that's involved following the telemedicine visit. Traditionally, the geriatrics telemedicine nurse has also been a part of our geriatric consult team and works with our other team members, the other members of the geriatric consult team, to facilitate transitions for those patients who are being discharged from the hospital as well. Just moving to the next slide. So this slide sort of highlights what the pathway looks like for the telemedicine program, the geriatrics telemedicine program. Starting with the referral. The referrals are usually faxed. Our sources of referral have grown over the years. Initially, we started off with just the primary care providers, the home visiting primary care providers, but now we've received a number of referrals primarily from specialists, the specialists that we've been working with over the years who would like to do follow-up consultations with their patients. Once the referral is received, the telemedicine nurse would then typically reach out to the family to see if she could schedule a time to essentially come and do a pre-assessment that is then summarized as a part of a nursing report and sent off to the consulting specialist. Once that happens, the specialist would kind of go over the nursing summary to give them a brief background on the patient's health history, any test results that is needed, either blood test results or other results. Then the face-to-face consultation would happen. So that would be facilitated by the nurse on the day of. The nurse would be there to essentially act as the hands, eyes, ears, everything for the specialist, and facilitate the consult that way. Depending on the outcome of the consult, a detailed care plan would then be created by the CNS in partnership with the specialist as well. And if follow-up is required, then the follow-up session would be scheduled either after the session or during. And then if there are any referrals that need to be made to other providers, the nurse would then facilitate that as well. The important thing also is that the nurse would then circle back with the patient's primary care provider, making sure that they are kept in the loop with whatever care plan or actions that are the outcome of the consult as well. Just moving to the next slide.
So since 2015, there's been 166 unique clients who have been referred to the program. And last year, I facilitated 195 telemedicine events, as well as facilitated 17 e-visits. And e-visits are consults between the specialist and the patient without having a nurse to be there to facilitate it. So I would do the education on how to use the technology and what they would require before the appointment. And then patients referred to the program are usually 65 and older, frail and or homebound, and reside within the TC Lynn boundaries. And the referral sources that we received our referrals from were from primary care, specialists, and hospital discharges. Next slide, please. So based upon this chart, many of the referrals that we received are for a cardiology consult. So right now I work closely with the cardiologist, Dr. Jeremy Kabulnik at Sinai Health System. And right now I manage about 40 of his clients, and they're being followed for congestive heart failure. During the summer, I was following maybe about 50 clients, and 10 of them, in addition to that, 10 who required to see a geri psych consult, a nephro consult, and a respirology consult. Next slide, please. Oh, next slide. And then a survey had been distributed to patients as well as their caregivers, and it asked, in their opinion, what were the greatest benefits of using this telemedicine service? And some of the themes which were identified was access, convenience, integrated care, and improved health outcomes. Next slide, please. In terms of final thoughts, some of the contributors to success were the availability of the specialist services from hospital settings to link with homebound patients, and strong partnerships with primary and community care providers. And I work with many specialists from St. Joe's, Toronto General, Toronto Western, St. Michael's, as well as Toronto East and Sinai Health Systems, as well as some of the barriers and challenges which we encountered were technological challenges involved with the technology, limited resources, for example, admin support, and conflicts in scheduling appointments. Next slide, please. And to conclude, we'd like to acknowledge the following contributors: Dr. Samir Sinha, who's the Director of Geriatrics; Nia Trong, who is the clinical nurse specialist, who will be back February 24th and has been here since day one in the program; and Kate, who is the Senior Clinical Program Director at Sinai Health System, as well as our collaborators to TC Lynn, Sinai Health System's Healthy Aging and Geriatrics Program, and the Ontario Telemedicine Network. Thank you.
Thank you very much, Janny and Nicoda. So we've got time for questions now. We'd like to ask the presenters who have webcams available, please put your webcams on now so that we can see you. And for attendees, we'd like to ask that you start typing your questions in the chat box. Just make sure you're putting it to all attendees, panelists and all attendees. So please start typing questions. So these were very excellent presentations, a lot of similarities, a few differences. Thank you to all of our presenters. We have a few questions that have come in already. So one of them is, how did you obtain funding for required resources for programs like a nurse or equipment? So any presenters who would like to answer, please just go ahead.
It's Kay McGarvey here with Dr. Norris, and this was funded by a Toronto Central Lynn special fund combined with OTN. So there was some funding for purchasing of equipment and room space, that sort of thing.
Great. Any other presenters with tips on funding?
This is Janny Lee and Nicoda Foster. So I'd say very similarly, our funding started with the Toronto Central Lynn, and we actually became a part of base funding a few years later, and the hospital has even chipped in supporting the growth of the program, and we were able to do that primarily through kind of demonstrating the significant impact that the program has had, not just on, with the patients as well in terms of their satisfaction with the care that they're receiving from the telemedicine nurse, but also in terms of the number of patients who are returning to hospital, who are being followed. As Janny has sort of highlighted, a significant proportion of the patients that she sees are cardiology patients, CHF patients. And so she actually spends a great deal of time working with one of our cardiologists and managing his CHF patients. And, we haven't seen any return to hospital, kind of post her involvement with managing the patients and keeping them at home.
So the experience at St. Michael's regarding funding has been somewhat unique. In 2005, the Ministry of Health was incentivizing hospitals in Toronto, as well as communities in the northern regions of the province, to take up OTN. And so they were being either given grants or monies to expand this program. And that's how I started, and that more or less has continued. And at St. Michael's, the OTN program is quite robust, I would say. There is, of course, the commitment to continually renew the equipment as technology improves, and as you've seen in my slides. So I, to me, it just it was a serendipitous thing that funding just came through because it was promoted by the provincial government in 2005.
I just want to add too, in 2013, TIP was part of an urban telemedicine initiative, and there were a number of different telemedicine focused, nurse-led clinics like telewound, teleophthalmology, telederm, looking at ways that we can use telemedicine in an urban setting, given the success of programs like Dr. Zorzitto's in the far north and underserviced communities. We recognize that a lot of communities in the city are underserviced.
I just want to add from Baycrest, in terms of the funding. So in 2017, we received a generous amount from one of the donors. Later on last year, we had some funding from the CABI, the Center for Aging, Brain Health and Innovation, for a Spark project. Right now, virtual care is pretty promoted at Baycrest, so a lot of the funding comes as a big kind, because we are continuing with virtual home assessment at the Day Treatment Center.
Great. Thank you to all of our presenters for answering that question. Another question has come in about what percentage of patients were appropriate for virtual care, and of those, how many participated? You may not have exact numbers, but just guesstimating, was it a high percentage, medium, or lower percentage of patients who qualified and who are also interested in doing it?
Maybe I can put my perspective in telemedicine. I would say 95% I find benefited from me being there, bringing in the internist geriatrician perspective. The case where it appeared to be purely social or psychiatry and no medicine, it's been really an exception. I would say.
I think you have to be very careful which patients you pick. Of the patients that we pick that are appropriate, most of them are very happy to participate. The troubled ones are the ones with addictions and mental health issues more commonly, or geriatric where there's a cognitive deficiency and they're protected. They don't want anyone else involved. But I think the challenge for TIP anyway, and I suspect the others too, is that it's patients are not being identified who would benefit from programs like this. And I recognize it's very difficult sometimes for primary care providers to keep track of all the different things that they could be doing that would help their patients.
And if I can add to that, I find those that seem to have benefited the most were those where the family was present and part of the intervention. They're the one where the recommendations are most likely to be followed, and that's an impression from the feedback that I got to the session or right after the session from the family.
So from my perspective, of course, they have a list of inclusion and exclusion criteria at the other end, and it's those communities that are actually selecting the patients. If they're really concerned, then they will give me a summary and I will screen them ahead of time. They will just fax me a summary to say, would this be appropriate or not? But in general, for example, if people are experiencing extreme paranoia and they're talking to the television, to have a televideo conferencing and have them assessed, that might not be appropriate. So individuals that are in a delirium and really more acutely ill, that may not be a good setting to have, telemedicine, video conferencing. People that are so profoundly deaf or blind and visually impaired, that may not work for them either, unless there is a lot of support around, either by other means of communication. So, but by and large, what I have found is that the providers at the other end, either intuitively or because they're following the inclusion-exclusion criteria, seem to select fairly well.
Yeah, I would like to add as well from our intervention. Like I said, we have developed a screening form for exclusion and inclusion. So most of our clients that are identified by the clinicians, guided by that screening form, would benefit from the virtual home assessment. And I would say from our experience, I cannot share the numbers, but the majority accept that virtual visit, the clients.
One thing that's been an enabler at Sunnybrook is we were able quite early on to link with a program going on at Sunnybrook where they were beginning to automate the process of identifying high users in the emergency department. So that would include patients that had 4 visits in 6 months or 3 admissions. And I'm able to get that list and sort of winnow out the ones that I think might be more sensitive to interdisciplinary care planning and approach those patients. So in a way, we bypass the primary care providers, although we do contact them and include them in the initiative.
And just to add from Sinai, so I'd say that, most of the patients that because our program is referral based, so most of the referrals that we receive are patients who are, highly appropriate. Again, a lot of them are, they have, physical impairments, or, there are other sort of issues that are happening that would prevent them from coming into the hospital for their, for their follow-up or appointment with their specialist. And so, we have been sort of able to, from where we first started with the initial pool of primary care providers, home visiting primary care providers, we've been able to build relationships with the specialists that we've been working with over the years to essentially, kind of facilitate or help them to manage those patients and keep them at home. And a lot of the patients that we have been seeing so far, first the patient has to consult, and I'd say 98% of the patients that we get referred to the program always consent to be a part of the program. And then the majority of them have been sort of followed up, or we've followed them for a year or more, even as well.
And just to add on to what Nicoda was saying, so right now I manage about a caseload of 40 individuals, and many of them require monthly follow-ups, so I try to coordinate that. And it's great because sometimes they do have a very difficult time going to see their family physician and getting their medications changed. So at least seeing me, I can be able to coordinate all that, as well as let them know in terms of what medications have been changed by their cardiologist as well.
Great. Thanks to all of our panelists for answering that question. We're coming up close to the end of the hour, and I'm cognizant of the great engagement from our attendees, and we may not be able to get to all of the questions, but we'll pose one last one. And they're asking, is OTN the only platform that everybody is using?
Yes, it is. It is.
Yeah.
Certainly at Sunnybrook, it's the only platform we're using.
We have billing tied to OTN use, so we actually have linked that together so that the family physicians can be reimbursed, and the specialists, depending on which hospital billing process they use, can be reimbursed.
So at St. Michael's, we use exclusively OTN because of well, I don't know if there are other considerations, but certainly the privacy and the secure network is very important for confidentialities. And by and large, I don't have to worry about that. And the old HIP billing is tied, I'm told by my support staff here, that the billing for the physicians is tied to the OTN as well.
And that's the same for the Sinai telemedicine program as well.
And same for Baycrest.
Okay, so it sounds like OTN is the current platform. So we have run out of time now for our webinar, and we want to just wrap up. I know that there are more questions, and most of the presenters have generously provided their email addresses, so we'd encourage people, if there are burning questions, to maybe get in touch with presenters. So thank you very much to Mireille, Rita, Marisa, Janny, and Nicoda. We want to thank the attendees as well. You'll receive a short evaluation survey by email, so please share your suggestions and topics for future webinars. And we wanted to point out too that this is part one of a two-part webinar, so you'll receive more information on telemedicine if you tune into our second part, and more information about that will be coming to everybody who registered for this one. We also wanted to highlight caregiver education strategies, which is free resources we hope every webinar attendee will share with caregivers of older adults with frailty. So caregiving strategies comprises online course, handbook, and website, which were developed by RGPs of Ontario with caregivers and healthcare providers as co-creators. Registration is now open for the online course, which runs from February 3rd to March 30th, and we'll circulate a flyer to help people spread the word. Our next webinar we'd like to invite you to attend is on February 28th, entitled Proposal for a Specialized Geriatric Services Decision-Making Tool, and it will feature Dr. George Heckman and Sophie Hogeveen. Registration information will also be emailed shortly for this webinar. So thank you again to all of our presenters and our attendees. Wonderful to have you all join, and we'll see you next time. We're signing off now.